Muidin waith agus míle fáilte ribs léir go dtí an webinar seo. This is the 8th coalition conversation from mental health reform. For those who don't know me, my name is Fiona Kyle and I am the CEO of Mental Health Reform. We are Ireland's leading national coalition on mental health. We are a membership-based organisation with over 75 members representing a diversity of interests, including members who deliver mental health services on the ground, those who work with children, those who work with disability rights, children's rights, human rights in general. And what mental health reform does is we bring all these members together to speak with one strong, unified voice on the need to reform Ireland's mental health services. We have a vision of an Ireland where everyone, no matter where they are able to access the mental health services that they need and have the best possible recovery outcome. So this is, as I said, the 8th in a series of community conversations that we've been having with the mental health community on a range of topics, but primarily looking at the impact of COVID-19 on mental health services in Ireland. Throughout those weeks, we've had hugely engaging conversations looking at the European context, the Irish context, looking at data from the Samaritans in terms of users of mental health services and how the needs and the usage is changing, to looking at the employment context, looking at psychosocial support, impact on young people, impact on women. It's been a hugely inspiring and informing series thus far. And, you know, when reflecting on each of the webinars, you know, one thing frequently comes up, and that is that alongside, you know, the huge impact and change in context in which we're working, there's also been a huge change in the policy context. With earlier this year, the launch of Ireland's new mental health policy, sharing the vision. And in each of these webinars, different parts of this new policy have been mentioned. And I think, you know, that alludes to that this new policy, it really provides a solid basis for looking at the recovery model in terms of the COVID-19 pandemic. The content in the revised policy has a much greater focus on mental health promotion, prevention, early intervention, and enhancing the capacity of primary and community service is hugely relevant to this new context, this strange new world we find us in. I think, you know, it comes as no surprise to anyone that, you know, mental health reform has been hugely advocating for many, many years, along with our members, for the publication of a revised mental health policy. It's been long overdue, as many of you know. And that, you know, that has been the work of the team in mental health reform, our members and other key stakeholders, including people with self-experiences of mental health difficulties, family members, carers and supporters. You know, mental health, the policy is fundamentally important. It sets out the change that needs to be done at a really high level. You know, the longer I think we continue to provide services into what we know are kind of ineffective systems, you know, the longer that we're doing a disjustice and disservice to those who are accessing and need to access those services. Mental health reform, we've broadly welcomed the new policy, including its vision, its principles and values. And we've really welcomed, you know, the reshaping that's envisaged in the policy of Ireland's mental health service delivery, and the shift to an outcomes-focused system, which centres on the value created for people using the services rather than the volume delivered. You know, it's at the end of the day, we're all looking at delivering services for people and adding and enhancing the lives of the citizens of Ireland. We're very welcome of, you know, the inclusion of a life cycle approach with a greater emphasis on promoting mental health and building resilience in all stages of the life cycle, in addition to a tailored approach for priority groups. The strong emphasis on the various detriments that affect mental health, including the socioeconomic, cultural and environmental factors. I think if the last, you know, 4 or 5 months has taught us anything, is how crucial those detriments are to our mental health. And I think that this is something that we hugely welcome in this new policy. You know, there's also a whole of population, a whole of government approach, which is also vitally important. Mental health, it's not just something that needs to be delivered by the Department of Health or the HSE. It needs to be mainstreamed throughout many, if not all, different government departments, and that's something, you know, that we really need to have leadership on and work towards. The greater emphasis on promotion, prevention, early intervention is all very, very positive. I think, you know, one of the key things, though, that we will keep referencing and holding all stakeholders accountable on is, of course, the commitment to the implementation, to having an implementation plan and the establishment of a national implementation and monitoring committee. This was a significant shortfall of the previous policy, and, you know, it's something that we need to really be implemented as soon as possible to ensure that the new policy is responding to the current context, and that we are from the earliest possible moment able to keep the implementation at the heart of the new policy and how we do things. Sharing the vision, you know, like all policy documents, it's not perfect, and mental health reform in their input into the policy development process brought together the views of the sector, and we had made a very in-depth submission, which we will link in the box during this conversation. And, you know, we're very welcoming of the new policy, but there are, of course, areas that we would like more detail on. There's areas that we'd like to discuss more with to the Minister and to other stakeholders. So since the policy has been launched, we have been bringing together our members as a whole and in subgroupings to really discuss the content of the policy. And I think, you know, a few things that have come to the fore, I will go through briefly. And we are in the final stages of, you know, putting the final input into a reaction, and we hope to be able to send that to the Minister and to the relevant officials in due course, and that it'll be a key document to open up a broader discussion on. But as I said, I think we'd all agree, and we'll be going into more detail in this webinar, that sharing the vision, it's a very different type of policy document to Vision for Change. It's conceptual, it's aspirational, and it does have clear and specific recommendations on certain aspects of mental health service delivery. However, in other areas, our members feel that it may lack detail, and some of those areas include, you know, in developing services and support for particular groups of individuals, including people from ethnic minorities, for example, the traveller community, women, and gender mainstreaming throughout the document, people experiencing homelessness, those in the prison systems, LGBTI plus community, among others. And there is a lack of clarity perhaps also on other aspects of service provision, including, you know, the out of hours mental health support and the role of the community mental health teams as part of such a response. And we'd also like to maybe discuss with the Minister and others that the absence of kind of, I suppose, any recommendation on effective regulation of mental health professionals operating across a continuum of support in a broad range of settings. You know, I know it's also been noted that the public sector human rights and equality duty, it's not, we would have liked that to perhaps be more strongly referenced in the new policy, notwithstanding the valuable proposed actions related to human rights and equality in the report. But we will be sharing this in more detail, and we see today as yet another input into the finalisation of that document, and we will have a question and answer section at the end of this webinar where we'll hear from our members and others. But overall, you know, sharing the vision, we feel that it provides really significant potential to improve Ireland's mental health system, and there's huge opportunity to develop progressive actions throughout the implementation process. But I suppose the question is, how do we move from words to action, you know, especially in this current context? And, you know, we know that, you know, we need leadership, we need money, and we need that oversight group. So, you know, there would be the key things that mental health reform would be calling upon. But yeah, so today it's all about, I suppose, understanding this policy a little bit more, hearing how it came about and hearing about the process and what happened next, and then to hear from the department perspective in terms of, you know, the key areas and the key changes that this policy can bring about. As always, this is a conversation, and, you know, please feel free during the presentations to use the chat function at the bottom of the screen. There's also a Q&A function, so please get your questions in early. I will be moderating those and putting the questions to the panel at the end of both presentations. So on to our speakers, which I'm sure we're all really eager to hear from. And we're delighted that we have two really kind of high profile and key people to come and speak to us today. So firstly, I would like to welcome Hugh Kane. I feel like Hugh probably doesn't need an introduction because he's been such a key figure in the mental health movement for, I think it's over 40 years now, Hugh, I've read. But Hugh was appointed in 2017 by the Minister as the chair of the Oversight Group to oversee the next stages of the review of the Vision for Change. And, you know, he has worked in the HSE and has also been, you know, the former head of the Mental Health Commission. So Hugh, will you come on and maybe share with us, you know, some of your thoughts on the process and kind of, you know, where do we go to next? Thanks, Hugh.
Okay. Good afternoon, everybody. Can you hear me?
Yes, loud and clear.
Yes. Sorry. Okay, it's kind of difficult. One, just to start, I was really surprised when I was asked to chair this piece of work. I would not have seen myself as a particular expert in the area of mental health. However, I did have, and I do have, an ongoing both professional and personal interest in the whole area of mental health. So despite my initial reluctance, I happily took on the appointment from the Minister. I suppose one of the very first things that struck me when I began to look at this was that there's no real procedure set out and no instructions to a chair or a group who's set to do a particular piece of work. And that of itself presents lots of challenges. And I think within the terms of reference that we had, it was a really, really complex piece of work. I suppose reflecting, say, on Vision for Change, one of the frustrations, I suppose, just looking at it, was that a lot of the reportage around Vision for Change very often focused on the number of staff who had or hadn't been employed, and the number of teams that had or hadn't been in place. And on some level, when we got together as a group and started to unpick that, we kind of felt that it was really important that we would start to focus more on an outcomes basis that would really focus on what we're trying to achieve and how people's lives are going to get better as a primary focus, rather than on the people and the professionals who are going to deliver it. I think the other thing that we determined to do then, in the absence of a written policy, was rather than following, doing things the way they'd always been done, that you put together a group that represents everybody who works in the system. And then on top of that, then you invite submissions through advertisements in public newspapers, where you get lots and lots of documentation in that creates a huge workload, and whether you're able ever to give justice to doing that. So for that reason, the minister determined that he would appoint a smaller group, and that we would engage in a different kind of consultation. And really what we determined we would do is that we would adopt a kind of a more democratic approach to a consultation, and that we set about meeting over 1,000 people in 5 different locations across the country, representative of everybody. So there were people with experience of using mental health services, their families, there were community groups, there were professional groups, there were different voluntary organizations, and we all sat, and the consultation happened in that kind of a system whereby everybody had equal right and equal value, and we were able to gather together all of the suggestions and difficulties that people were experiencing. So I think that was a fairly different kind of an approach to it. I suppose as chair then, my role really was to facilitate the group, that they would, that they could have really wide-ranging and open and honest kind of discussion, that we worked really, really hard to achieve consensus on issues, and when we couldn't do them in the big group, we broke away and came back with proposals. It was a way really of trying to value really everyone's expertise and their views and opinions. But all of the time, my question as chair was, how does that impact on the life of an individual? And that was kind of the focus that we kind of to drive through. I think one of the things, we were accused of being very, very slow in our work. But I think there were a number of things intervened that slowed us down a little bit. But as part of our own processes, we did spend the first 3 or 4 months thinking and talking about what are the issues and how we might approach them, and kind of trying to form a way of moving based on that. So I think that particular way of working helped us to I think come up with set out a framework whereby we could develop a document from which the policy would be built. And it was, there are a number of key points, I suppose, emerged. We took information where, there's lots of information had already been developed, So for instance, the work, WRC had developed a policy in ahead of the policy being developed. They conducted research around best practice internationally, and that was available to us right from the get-go as well. We also looked at, the other thing we did as a group then is we commissioned an external review to establish the actual status of the recommendations that were envisioned for change. So what was implemented, partially implemented, not implemented, and maybe not relevant any longer. We also took on board all of the submissions that were made to the Joint Directors Committee and withdrew from them the key messages from us. We looked at submissions were made, say, for the suicide prevention policy Connecting for Life. And then obviously we had the output from our own town hall meetings that were there. We also established, we had a reference group of other stakeholders, of professionals and agencies, and we had output from there as well. And the mental health reform itself had done a survey on the experience of people using service. So we kind of used a framework to gather all of the key messages from all that data to help us to drive and develop a new policy. And I think at a policy level, what we were trying to do at a set a very, very high level vision and direction where we think mental health services need to go. And I suppose one of the things, I trained as a systemic family therapist, and I know that, you know, one of the things that systems theory will tell you is that systems are inclined to collude to keep things, to maintain themselves. So part of the way of our working was on some level an attempt to disrupt the normal pattern of doing things, so as that we might come up with something that is much more reflective of what a broad stake of people were telling us. So from that particular work then, it was very clear that we needed to develop a stronger, more appropriate mental health support at community and primary care level, and to develop robust and reliable supports to ensure the effective use of inpatient care. So the policy really focused strongly on developing that kind of broad-based whole system mental health policy for the whole population, and also developing specialist services where they were required within specialist mental health services. And I think the other thing that was very clear to us was that mental health of the population and specialist mental health service isn't only the responsibility of the health system, that it was really important to involve all of the other players, all of the other government departments that are there, all of the voluntary and community sector, because it's really, really important. And we all know that over the last few months, the things that has kept us all well has been our communities, our families, the people that we work with. And I think one of the issues that we were hearing very clearly going around the country was that if someone has a severe and enduring mental health problem, that they need all of those normal, usual supports that the rest of us enjoy as well. And that was really, really important. I think the other key piece for us was that the policy, we were looking for policy was going to be action orientated, and the policy that would bring about tangible changes in people's lives, especially people who are experiencing mental health difficulties. And that, therefore, what was required was a change in how service and supports are delivered. And again, I think our view was that was best achieved through a policy that focused on delivering outcomes for people. And by concentrating on outcomes in our report, we think that will support significant changes in delivery of mental health services and ensuring that people have better results as a result of that. And I think as well that whole life cycle was really, really critical. We explored, and that's why we thought it was really important to it, because it's really important that this is a health policy focusing on the health rather than ill health. And in that sort of a context, you must sort of start to build actions that from building resilience when we're younger, through prevention, early intervention and treatment of mental health issues. And then moving on the other side of that to ongoing support for those people with complex conditions. So that, that if as a society we begin to develop that kind of resilience, that we learn skills and competencies to manage difficulties that we all encounter, that in an overall context helps us all do better. I think for us, there was a lot of talk out on the road about that recovery was really, really important, and that that within the policy that we were really, really strongly sort of saying that we've made some recommendations around that. But I think the other piece, and we made some recommendations around this in the policy, was that people experiencing mental health difficulties and their supporters, where that's appropriate, have to be centrally involved in their own care. And that recovery is planned and delivered in that sort of a context, that the person owns their own recovery journey, and us around who are working or supporting them play a role in supporting people to do that. The other thing that was really, really, came across to us that because of the lack of very basic services at a community level, that people had to get very, very sick before they could be referred into very specialist services. So people spent a lot of time waiting for something, and when they got there, it wasn't an appropriate response for them. And on the other side of that as well, it was the other thing that we picked up loud and clear was that within some of the acute units, that people were so ill getting into them because of the lack of anything else, that they were nearly anti or counter therapeutic. And also then that people were being discharged earlier than was already because of that pressure. So I think what we were trying to make sure was that there were really good supports right from the bottom all the way up. And when people leave, that very special thing that the support's on the other side as well. And I think, you know, that for us, where we talked about, and we have within the policy, really clear pathways we talk about extensive use of shared care models and ownership of care and supports. And we were really struck by this, you know, care. People said that the care was being denied because of siloed working, where people were falling between services. And so we flagged that in the report. But we also sort of, you know, and we've been accused of not being as precise as the original vision. You know, we're still sort of saying that there has to be adequate resourcing, adequate staffing and settings. People who work in them must be properly and effectively deployed and governed. And staff must also be adequately trained, supported and valued in the setting. And settings have to be appropriately located. So no longer should a mental health service be delivered out of an old building in the back of an old hospital. It should be part of the mainstream delivery, you know. And just two other quick points. I suppose there was a big issue around the recruitment and retention of appropriate staff, and lots of the difficulties about completing teams was the unavailability of particular types of staff. So in our discussions, we determined that rather than recommending that we should have more of something that isn't available to us, that we would sort of say what was set out in vision in terms of what should be the core requirements of teams should be there, but where particular parts of those teams are not available, that there would be some level of flexibility to look at a local level where people look at, well, what are the outcomes or what are the needs of this particular population, and see who else can be of assistance to us in delivering some and achieving some of them outcomes, rather than waiting for the truth to come over the hill that may never be there. And I suppose the other issue then that I just want to, before I finish, we're aware that in many mental health services, you know, the use of inpatient beds is over 100%. You know, yet we still have more beds than was recommended in the original vision. So rather than continue to add on beds, what we recommended in the report was that people and services would be asked to ensure that there were sufficient community-based services there, and that until you exhausted all of the ability of those services to deliver support that are required, that only at that point should the issue of beds come onto the table. And I think while that creates, I think if we keep doing what we always did, adding on more beds are the most resource intensive piece that we have at the minute in the system. And I think we need to develop and continue to develop and prioritize the community-based supports to support that. Yeah. So look, Fiona was on about next steps. I always loved, I remember someone quoting me that in Ireland, we suffer from implementation deficit disorder. So given the amount of work that our team have put into developing the report on which the policy is based, it's really important for us that implementation takes place. So in terms of next steps, I think it's really important that there is a very high level commitment at government level to actually implement the policy, to set the timelines in which it'll be done, and to set the priorities. I think it's really important that we recruit champions to lead the work in the different sectors and work areas, because it is a very wide-ranging, there's a wide-ranging group of stakeholders involved. I think it's important that we don't get caught into sectors or silos, that we need to prioritize the high-level achievement of outcomes that make the biggest impact as quickly as possible. I think obviously in an implementation group, a high-level implementation group has to be established. And I think that particular group needs to be supported by expertise in implementation science. So there's a real science around implementing policy. And I think it's really important that if we have that high-level group, that implementation science is right there at the table and is available to the system, the whole system that's going to implement it. I think that national group would give high-level guidance, would have a coordination role, it would help prioritizing, driving and reporting on progress. And I suppose, given the many different stakeholders that are involved, each area of work will need subgroups working in different areas of policy and different lead agents as we go along. So they're about the comments I'd make, and I'm very happy to discuss further. And obviously, when you chair a group, you never get it all right. But I think if most of what we got is a good basis for a policy, that whatever other suggestions are made, that can only enrich the process as we move towards implementation. Thank you.
Thank you so much, Hugh. That was very, very interesting, and you know, certainly some of the kind of, I think you might have had some more sound bites there. I like the fact that you said, you know, that the focus needs to be on health rather than ill health, and
yeah,
you know, there's a huge amount of work still to be done. I think it's fair to say, in breaking down the stigma that is around mental health, and you know, the shift in culture that's needed across institutions, that this is something that's owned by everyone. But I'm going to move on. There's a lot of questions coming in, but I'm going to take them all at the end. And I'm going to move on to the next speaker, which is Tom. So Tom, if you want to share your screen and your presentation while I introduce you. So someone else I'm sure who's familiar to many on the call. So Tom O'Brien is the program manager in the mental health unit in the Department of Health, and Tom has been very actively supporting the Oversight group to complete its work, and he has extensive I think experience in delivery and management of social services, having worked with both the HSE and the Department of Health. So Tom, the floor is yours.
Thanks very much, Fiona, and thanks for the invitation, and thanks to Hugh as well, because he gave a very good overview of the work that was done, and I suppose he didn't really share the complexities that were really in the background, both politically and also from various community groups who were unhappy with how mental health is being delivered. So a very broad brief that the Oversight group needed to take on within a very short time frame. I think the original time frame, as Hugh said in the terms of reference, was a year. So to take on mental health in all the components that were there and to do a good job within a year was going to be a difficult task at the outset. But the report that the Oversight group provided is sharing the vision, and you've all had a copy of that, hopefully, or it's online. And as you had said, Fiona, it is based on not just that your mental health is a health issue alone, but also that it's influenced by many other things going on around you. And we had to take that whole of government approach then into designing the policy to ensure that not only did the Department of Health have the obligation for implementing and for working with the HSE to implement, but also that we needed the Department of Education and Justice and Social Welfare and everybody else involved as well, if we were truly to make some sort of impact on an individual's mental health and the influencers for ill health. So Hugh already talked about the outcome-based framework. And again, this was looking at a vision for everyone where you were talking about very low-key mental health issues, mild mental health issues, and then back up to very complex and enduring needs. And so I think this sharing the vision document does look at an awful lot of those areas. And I'm going to talk later about the implementation process, because I think a number of questions coming in are that this is a very high level document, and in very important areas it's very general, and that's done on purpose because there is a next phase coming. But the idea was that this was a population-based approach and a whole of government approach that focused on the individual rather than the mental health problems of the system. So the tiered approach, a stepped care approach, was adopted by the team. And as Hugh had already said, it was based on very good, extensive consultation with very many people from various different backgrounds. And then, as you also mentioned, based on WRC report and based on best international practice, it was based on an outcomes where people could have tangible outcomes in their mental health. And so the idea then was that the vision for the continuum of mental health services, this is the sort of centerpiece of the whole policy, was that, if somebody needed to access support, that access should be made available as quick as possible, and that there be several access routes for the individual to take. And I think the document really does talk about enhancing those access routes, creating pathways for care, based on individualized care plans, based on mutually agreed key working, and the composition and skill mix of various community mental health teams, primary care teams, and people working together. And indeed, I think the document is also quite strong on working with the NGO sector, where the HSE and others fund very viable worthwhile projects in the area of mental health. So again, the group was trying to look at what is it that we've heard and how do we transfer that into a service delivery that's tangible. You didn't want to have recommendations that were just going to be too complex, that you'd never see the light of day. We actually wanted to ensure that an awful lot of the actions could be delivered on and would be delivered on within the time frame of the policy. So based on that, some of the key recommendations are around shared working, the development of outreach teams, the enhancement of telehealth. There's a bit of controversy over the 0 to 25, but again, I think I'll talk about that later with the implementation plan. We talked about dual diagnosis, early access, social prescribing, quality and oversight, which was also something that was really needed in terms of delivering. And if you were working with online telehealth, and if you were working with shared teams outside of HSE, you really have to ensure that data protection and quality and oversight are there. What's important is that health and well-being is there, and health and well-being, the actions are quite small in terms of numbers. In fact, the first action for health and well-being is that there will be a health and well-being strategy. So that involves a whole other piece of work with Healthy Ireland and Sláinte Care and with the HSE. So that'll involve a whole new report, which will have several more recommendations, we're hoping, around developing people's health and well-being. And of course, we're looking at the intensive care rehabilitation units. And developing those forensic supports that we know support people to get off wards quickly and to go to a place where they're supported for their health. So really the next step for the department was, well, again, what do we do with this policy? So again, we do know that an awful lot of the policy implementation piece is essential. So what we need to do is we need to have a structure that will implement the policy, but also one of the criticisms of the policy and the previous policy was that it didn't have a very clear roadmap in the back, which would kind of give the time frame for implementation. So what we tried to do was to match each recommendation with various actions and outcomes and time frames for individuals then, so that people who were sitting at this committee could have a very good way of looking at, well, what are the priorities for this group, but also how do we hit the ground running. So in order to support them to do that, we have that implementation framework at the back of the document. It was going to be a separate piece, a separate publication, but actually the department felt that if it was in there, well then it would ensure then that people would work together and that people would have a shared understanding of the direction that we want the policy to go. Because I think, again, some of the criticisms of previous policies are that, you know, each CHO manager could interpret a policy in a different way, and then one CHO area could go off on one way and another CHO area could go on another. So what we tried to do was to make sure that the implementation process was shared and that it was standardized to some extent, although being flexible in how services were delivered. So the next step for the Minister Butler, is very keen to ensure that the structure is established very quickly. The problem with being quick is that, you know, you don't want to miss out on some key people that need to be at the table. So at the moment, the department are working on draft terms of reference. We're meeting with the HSE and the Minister to discuss what a National Implementation Monitoring Committee ought to look like. And I think again, a lot of the recommendations in the policy are very general. So this also is a very general high-level structure. Underneath this structure, there will be several subgroups, because some of those recommendations are talking about clinical programs. Some of them are talking about the CAMS teams and the extension of the age profile from 0 to 25. I think what's important about that particular recommendation is, you know, that the policy was certainly, people were saying maybe there's better ways to do it, but we weren't saying that the current system or the current structure doesn't work, but that a conversation might need to happen. But we at the policy and the oversight group, that we couldn't have the time or the expertise to go into those difficult areas. So the recommendation really is to establish a subcommittee that would look at that question. And if they came back with all of their expertise and said to the implementation committee, actually, the way things are done at the moment works and it's effective, well then the implementation and monitoring committee we would assume, take on that recommendation from the experts. So again, there'll be other subcommittees as well, looking at education prevention, looking at women's task force, looking at the clinical programs with ADHD and eating disorders. There's a lot of work that needs to be done. And so I think what needs to be communicated, I suppose, to all of the stakeholders online at the moment is that the policy was never going to be prescriptive around everything that needed to be implemented. But what they were saying was, you know, these are the areas that we need to focus on, and where there needs to be a lot more work done, well, then we need to encourage subcommittees to be developed under the National Implementation Committee, reporting into that committee, developing other pieces of work, and then that would be I suppose, fed up into the Cabinet Committee of Social Policy and Public Services. So the actual committee representation that you see on the diagram there, it was built in such a way that it reflected the current setup for the Connecting for Life policy. That seems to work. It has the Cabinet Committee, who are the government, I suppose, people responsible for implementing policy and having decision-making powers. We also have government departments feeding in, HSE and lead agencies, the national steering and implementation groups, Healthy Ireland, Sláinte Care, and whoever else needs to be there. Again, it was never meant to be an exhaustive list, and that is being worked at the moment. At the moment, I think the idea is that we would have that committee, or certainly the terms of reference, prepared for September, and that the Minister then would review those with the Department and the HSE and others to see how best this implementation structure would work, what types of subcommittees need to be there, and how we can then work on developing this policy and leading out on it very quickly. So that's really, I suppose, what I have to say, Fiona, that there are next steps, and we'll be hopefully developing that around September.
Thank you so much, Tom, for that really informing presentation. And it's thank you for, you know, I suppose there are a lot of questions even have come through that you've already answered, I think, in terms of the next steps. Yeah, so I'm just going to dive straight into the questions so that there's maximum time, and there's a range of questions coming through on different topics. So I'm going to try and maybe, you know, for the ease of Tom and for Hugh, to group them together. And something that was raised, I suppose, in both your presentations, and there are some questions that have come into it as well, is around that cultural shift that's needed. So, you know, I think that that's very much at the heart of the policy, is kind of moving, I think, as I picked up with you, from kind of mental health rather than mental ill health. And there's a huge amount of work, I think it's fair to say, to move the system with this new policy. And some of the questions that come in around that, so a question around someone who's emailed in said, you know, a well thought out and progressive future for mental health services, but if clinical leadership doesn't change dramatically, as is noted in the policy, will leadership and power, it'll remain in the hands of, you know, the consultant psychiatrist, and the culture will remain the same, and how do we move towards, you know, I suppose the outcome recommendation that is envisaged in the policy. Another question coming through, and this has also come up on in our analysis, is around so I suppose the prevention piece and the role that is envisaged for Healthy Ireland in terms of the kind of health promotion element. And what's come in is the fact that, you know, Healthy Ireland are still very much at the beginning of kind of interpreting their role and their understanding of mental health, and how can we ensure, you know, that they're kind of the right organisation to take this forward, and how do we kind of shift cultures in kind of different institutions. So maybe if you both want to respond to those, and then I'll gather a few more. If people want to put in on the Q&A or on the chat. So maybe Hugh, to you first, because
Okay,
you
yeah.
spoke about the culture, and what are your thoughts maybe on a forward-looking perspective on both of those kind of comments?
Okay, I suppose there's a couple of things. I think at the essence of the change, I think on the cultural side, is around the empowerment of people with difficulties to be in control, so that people who are unwell, that they are in the driving seat of delivering their own recovery, and all our roles are in support of that. I think it's really, really important. I think the other side on the cultural piece, and it links one of the questions as well, is that, you know, lots of different people have a role in people's recovery. Not just, you know, so obviously there are a range of mental health professionals who have a particular role. But if somebody, for instance, you know, doesn't have a good place to live, like no matter what a good job the mental health professionals do, they're always going to be in trouble there. If people haven't got, you know, lives in terms of education or of work or of training, well, again, that's obviously going to impact as well. And then the whole piece of people's relationships within their families, in their communities. So the shift is really about being that more holistic approach to dealing with stuff, rather than, you know, in a kind of a way of just the mental health people look after that and the rest happens by chance, whereas we're talking about a much more integrated way that the whole of people's needs get met in that sort of a context. I think to develop that kind of culture, that's why we've talked about the role for community and voluntary sector, other government departments, and supporting all them in a very structured way. I think that's just really, really important. We looked at this clinical leadership issue, and what happened really was that we were anxious that there would be a leadership within the specialist community mental health teams that would not be exclusively in the realm of a psychiatrist. However, current legislation really puts the power in the hands of the psychiatrist, and that's why we made a recommendation recommending that sort of a change that would facilitate a different kind of leadership. On an interview, we also talked about having people in team coordination development roles as well to support that. So there's a legislative requirement to change the clinical leadership that I think is required as a matter of urgency. The other piece then, in terms of Healthy Ireland, I suppose one of the issues that if you set up a specialist mental health policy, again, it becomes a silo where it only focuses on mental health. And there are lots of other health determinants that impact on our mental health. And in the same way, traditionally, if we set up a Healthy Ireland group, their role is to look after the health promotion and prevention of everybody in the community. And if people with mental health are not included there, well, then there's an assumption that someone over there is doing it. So our preference was that to mainstream stuff as much as we can. So if we have a Healthy Ireland structure doing health promotion, well, they must take on the role of mental health promotion, but in that, build the competence, build the expertise, and ensure then that people with mental health difficulties access all the other health promoting requirements that all of us have as well, and vice versa. Is that okay?
Thanks, Hugh. Is there anything you would like to add, Tom?
No, just again to say that I know mental health reform, and a lot of the advocates are looking for the National Implementation Committee to be established immediately. And I suppose the delay is there, that there is an awful lot of thought that needs to go into it, because what I see from a lot of the questions at the side there are, you know, around the multidisciplinary teams, the leadership roles. This is a policy. So what it's doing is it's saying this is what we need to do as a country to move forward with mental health. Those, what happens underneath those recommendations needs to be very carefully discussed, because there are a lot of implications to job specification, as you say, legislation changes, possible makeup of community mental health teams and primary care team liaison work. So that implementation team, I mean, you know, at the outset, an awful lot of the recommendations, the short-term recommendations, which is 0 to 18 months, a lot of those talk about the establishment of those committees, which are to look at those big issues that are going to come our way. Because certainly, while we got a little bit of criticism, I think, in the department for not naming specific disciplines as part of teams, what the document really talks to is this multidisciplinary need to include everybody who has a professionalism as much as possible to assist an individual move on and progress through life. So the implementation committee is going to be a very, very important structure, not only to discuss what the priorities are, but also how do we go about moving forward. So that structure will have multidisciplinary team representation on that structure, who'll be able to challenge whether the legislation for psychiatry is something that can't be moved, or to offer solutions around more flexibility. So that multidisciplinary teamwork will be part of the subcommittees and part of the implementation committee. And that's why it's taken a lot of time really to think through that we're doing this right.
Yeah, thank you for that, Tom. And just following up, because there's a few questions coming in, and I think, you know, even in the questions and answers and in the chat box, you know, some of this debate is happening. You know, I think, you know, we have question coming in there, you will have seen from someone asking around, you know, why is there a desire to change the clinical leadership? Surely psychiatrists is best placed to lead in the area. They're trained and should be trained in providing holistic care. So that's coming through. While then there are questions kind of coming in terms of, you know, I think there's a really good suggestion from Niall Mulligan from the Samaritans in relation to the implementation of the National Sexual Health Strategy was supported via an implementation working group, and key to this was having clinical lead roles, and that made quite a difference. And then others are kind of asking, you know, is the plan to open up the leadership roles to a more diverse range of professionals? And, you know, people are asking and kind of, you know, that they should be kind of opened up to other, you know, other professionals. So that debate is happening in the chat, and it'd be interesting to hear your thoughts on that, because it's probably reflective of the process that needs to happen, and if you have a timeline around those as well. And I think, you know, another thing that's come up is in relation to, you know, the staffing mixes, and how Vision for Change obviously had baseline tangible numbers. And there's, I suppose there's a fear there now, and it's reflected in some of the comments that, you know, there's nothing to persuade, as someone says, those who hold the budgets, you know, that it's all down to the budget holder, and that they need, you know, more of a particular discipline in line with the policy, that kind of persuasion is now gone. So it'd be good to hear your commitments on that. And then there was a comment that came in around I suppose the shortage of supply, which we know we have, of appropriate staff, especially in the community teams, and is there a need for policy and practice to support the training so that we have increased numbers of required disciplines to solve the supply issue in the long term? So maybe, you know, there are a lot of the questions are coming in on this topic. I'm just going to see if there's one as well, just before I go back to you, around the crisis cafes. And the primary going to be with the AP, so those assistant psychologists. And do you think it would be more beneficial to staff in a way, particularly since AP jobs are so few and far between, and there's intense competition? Yeah, so there are a lot of questions I've thrown at you. But yeah, Hugh, do you want to respond?
I'll just give a view, I suppose. About the leadership of the teams, there's an assumption, you know, what we're looking for here is the person with the best leadership skills, and whether that's a doctor or a nurse or whoever it is, I think it's whoever is best at leading is the person who should be leading the team, and it shouldn't automatically fall to one particular profession simply because of the profession that they hold. there are obviously some exceptional psychiatrists who are leaders, but I'm sure there are other professions who are also exceptional leaders as well. So our view is that the leadership role is a particular skill set that's required and a set of competencies, and whoever best hold them is the person who should hold that. I think that was kind of the view that we were coming across. I think the Vision for Change did set out the minimum requirements, and we're not, you know, that's still there, you know, so and you know, so one policy translates into the other. So the way Vision for Change sets it out, we haven't as such sort of said, you know, that should continue, that if people are setting up teams, these are the core pieces that are in it. I think the issue for us was that if there is a shortage of people who can fill those roles, do we sit on our hands and wait until we get more people trained and, you know, and do nothing in the interim? So that's why we were starting to include a recommendation around, you know, seeing who else can help and support in that. And I think there's a whole issue around staff shortages that is a little bit wider than just the mental health services. And I think we mentioned that within the policy. You know, so, you know, recruitment and retention is a regular challenge in all service industries, including healthcare. And there are lots of issues impacting on that recruitment and retention. Some is around rates of pay, availability of accommodation. They are the key ones. And I think the difficulty for us in the policy here, there were people trying to get us to make recommendations around, you should pay this kind of a profession more, and then you get more of them. And those fellas there who are this level, they should be a different kind of a level. And so in terms of setting at a policy level, we kind of step back from making those kind of specific recommendations around specific grades and staff types. I think the issue really for us is around that if the budget follows the achievement of outcomes, that's where the change starts to happen. So that if people are very busy, creating kind of throughput, that won't get funded, that people will get funded on the basis of delivering actual outcomes that are set out in the operational policy. And that's where you start to get a little bit of a change. And I do think, you know, that at a budget holder level, that's a much more sophisticated way and does require different sets of skills and competencies to deliver budget based on outcomes as well. You know, so it starts at the department level, that if they're allocating you funding, it should be directly linked to the achievement of particular outcomes. And then within the system, then the funding follows then into wherever those outcomes are being delivered. I think that's kind of the essence of what we're saying on that one.
Yeah, thanks. Hugh, I just had a few follow-up. Oh, yeah. Sorry, go ahead. Yeah. I just had a few follow-up questions just to put to you in terms of, you mentioned, and maybe we picked it up wrong, in terms of that there was legislation that needed to change the lead. So there's people who are asking, quite a few people are asking, what legislation were you referring to there?
I'll have to find. I don't know if Tom has that one. We were certainly advised, and we looked at that the mental health legislation provided for a specific set of roles and responsibilities around the consultant psychiatrist. And that's the piece. I just haven't got the reference to it here, but that's what we were speaking about. We can
send it afterwards to people.
Yeah, absolutely. We'll have a look
not to stop the flow of conversation. But do you want to continue with the crisis cafes? Yeah.
So just in terms of crisis cafe, I suppose one of the, again, based on feedback, or one of the challenges was that if somebody was unwell, that the place to present out of hours was into an A&E department, and generally. It was a lot of people who got into difficulty were people who were already well known within the services. Yeah. So the whole idea then was to try to provide something alternate and more appropriate, and that's where the crisis cafe model that we've seen internationally is working really, really well. So it's where people don't have an underlying medical need, where it is a matter for the sort of emotional and that kind of support, that you would support it, probably run it. Maybe through some, we recommended trying a couple of them, run them through the voluntary sector, but ensure that there was enough professional input there to ensure that the appropriateness of what was happening and whether people needed onward referral. So it was just start to look at how else we might have an alternate source of access for people who get into difficulty out of hours. That was kind of the key thinking behind the Crisis Cafe.
Thanks. Tom, do you want to come in on some of those thoughts and questions that have come
No,
through?
just to concur with Hugh, and I think the issue with the legislation was really, I think, twofold. One was legislation, but one was, I think, mainly contracts based as well in terms of current HSE guidelines, which aren't unmovable. So again, but we weren't, as a policy committee, we weren't going to sit and talk about doing those kind of things, again, because Labour Court implications and all of that. So again, it's just important to say that the idea is there, and the context is that the recommendation is saying let's establish a committee and let's look at the roles here and let's see what can be done better. So I mean, that's the positive out of it, and whatever way the structures emerge after that, that's up to those people who are involved sitting around the table. The crisis cafes are only one component of very many hopes and desires. I think standing behind a lot of the things are how can we get people off wards quickly so that they can get back to their communities. So there are things around day units, things around community outreach supports, home-based supports, wraparound services for individualized care. Now, some of those things are already happening in pilot projects, and again, they seem to be requiring an awful lot of thought, because again, there are clinical and governance implications, and so they need to be thought through as well. But the idea is that there are alternative routes for a lot of ways into a service, and also the telehealth area as well, which is growing quite rapidly, especially because of COVID. It's not there to replace anything around face-to-face, but it certainly is a very good way of maintaining that therapeutic relationship with the client and making sure then that there are referral pathways online or through a hospital with the work that's being done with the NAS. From the department's point of view, I suppose this is a 10-year policy. It's going to be going on for a long time. There's a lot of work to be done, but at the moment, it's a good time for mental health. I see a lot of questions around budgets. That's a kind of a grey area. The previous minister, Dedi, was always saying, well, you can't compare like for like between Ireland and Europe because we have different ways of spending on mental health. So where other countries might have a specific mental health budget, we might have shared mental health budget, which runs into social welfare payments and medical card payments and different budget heads. But the idea is that there is a commitment from government, and certainly the programme for government that you would have seen features mental health stronger than I've seen it in 20 years. In terms of the priority that mental health has from a government. And I know that Minister Butler and indeed Minister Donnelly are both very, very keen champions of mental health. So I would imagine the best work that we can do at the moment is that implementation committee, once it's formed, there is a budget allocation that can be dealt with, but also at the moment, what we're going to be trying to look at is to kickstart some sort of budget so that come January, the estimates process will be quite sound around mental health. But again, if it's a staffing issue and there are no staff, well then, why are you looking for budgets for staff that aren't there? So there's a lot of background stuff that we need to work out to ensure that the budgets that we ask for are spent effectively, because quite often they're not. And then you're running around scratching your head thinking, well, why are we asking for more money if we can't spend what we have? That's more to do with planning. And this is what this policy is good at, is kind of saying, well, look, these are the short-term things that you can do right now if you invest in them. And certainly that's work that I'm engaged in at the moment with the Minister, is around what kind of budget we can allocate fairly quickly to develop some of these pilot protocols now.
Thank you, Tom. And I think from mental health reform perspective, it's good to hear, around the piloting, and with any new development, even the crisis cafes, we'd be very keen to ensure that there is, there's a service user led input there, because they know best what they need, and that there is an evaluation process as part of that as well. And
they're written into the policy.
Yeah, because I do think some of the kind of critiques that I think we were all aware of the last policy was that things were nitpicked at CHO level and on other levels, and that if we're going to go for a change, we need to be ensuring that the change is right for those people who will be accessing the services. And just a few questions, I suppose. So on that, there was, what are the provisions in the strategy for feedback from service users and accountability to service users, which I think is, a really key question. And then there's one from Sarah who's asking, is there any plan to address the recommendations laid out by the Youth Mental Health Task Force from 2016 as part of this strategy, given that the only reference to it in the policy is an erroneous one that, you know, the change of the CAMS age. So there's that, and I think you've already spoken about the budget kind of element. So yeah, if you want to take those questions, we're slightly over time, so I hope you're able to give us 5 or more minutes of your time to answer some of the few final questions that are coming through.
I think just in terms of feedback and accountability for service users, I think we haven't a specific line around that. But I think the whole the drive through is that people are responsible and the leaders of their own care and are entitled to be key drivers of that. So I think that cultural shift gives one angle on that. But I think, you know, there is a gap somewhere around how service users can, you know, obviously is a complaints process there if people are unhappy. And that is some way of, if people are unhappy with what is about the service that they got or how things turned out. So there is some element in that way. But in terms of specific recommendation on that, I don't think we've made one. And that is probably a gap, you know, now that's raised with me, yeah. Yeah.
Well, one that can be addressed, I think.
Oh,
you know.
Can I make one quick point about budget? When we're talking about budget in the context of this policy, we're talking about the existing money that's used. Is it being used, you know, in a policy appropriate way? And if it's not, it needs to be transferred to that. Because if we focus all the time on the new money, we're only looking at the tip of the iceberg. Because proportionately, the new money is always a tiny fraction of what's there. So the budget must include the whole spend that's there, the appropriateness of that spend, and is it being spent in a policy appropriate way, I think is the other comment I would make on budget. Sorry, Fiona.
No, that I think that's a very useful comment. But Tom, you wanted to come in as well around.
I know, just to say that in the implementation structure there, you'll see there is a service user representative on the NIMC, and it may not be an individual, it may be individuals. And again, underneath all of that, you've got peer networks working together and recovery colleges as part of the feed into the subcommittees that might be there. So I think right from the outset, we've had a strong service user stakeholder input piece into the policy development. And again, I think the policy is very strong, and we're getting a little bit of criticism as well, is that we're probably over-relying an awful lot of the work on the NGO sector. But again, when we talk about that shared working model, the HSE is funding an awful lot of very good projects outside of the HSE, and to be able to share those professionals and therapeutic interventions would be great. In relation to the youth mental health policy, I was a part of that group. The idea is that an awful lot of the stuff that's happening there, it's just not been reporting, but there have been great kind of pieces being done within current service plans of the HSE and Department of Education. So there have been perinatal interventions and perinatal training. There has been teacher training as part of new teacher education roles. The education in primary care or in primary schools has been extended. Counselling in 3rd and 4th level is being produced as well. There's an awful lot going on, and so the individual there, I'll find out who you are, and I can give you an idea of that. There are 2 or 3 pieces on youth mental health that haven't been done yet, and namely, it's the elephant in the room is that Pathfinder project. But there has been a lot of work in the Department of Health. Certainly, we're keen behind it, and that piece of work is going on at the moment with the minister, who's very much aware of it, and there's an awful lot of advocacy going on about that as well. But in terms of reporting, the work of the task force finishes in December 2020, but the recommendation in the policy, I believe, is that that should be implemented. The problem with the youth mental health task force was, again, the recommendations were quite general in some areas. So it's how do you measure whether it's done? The answer is you can't. But what we have been doing is chipping at certain areas that were prioritized. And there is a piece around a youth advocacy service that also has been left out, again, because we're looking at pilot projects that were being delivered and getting evaluations on that from the adult services to see how well they worked. So I don't think there's many areas of Youth Mental Health Task Force report that haven't been touched on besides the Pathfinder and the advocacy, but those two pieces are still going on and they're subject to a huge amount of work in the background.
Thank you. And yeah, just a comment from my side on kind of the service user engagement. And I think, you know, it's very much, as you both said, it's at the heart, the person is at the heart of this new policy. But I think it's often beneficial, you know, to take a step back and to, you know, I think we're all very aware of the recovery model and, you know, a person-centered model, but not everyone is, and the structures that are implementing much of what's there, the structures perhaps aren't set up to respond. And I think it goes back then to that cultural element that we really need to do a lot more work on, you know, even as a sector. I think, you know, everyone in this call is probably aware of the policy and aware of what we're talking about, but if we were going to maybe go down the road to a different government department and have the same conversation, Tom, I'm, you know, how aware and how informed would people be? And we all need to be aware of, we all have a role to communicate and to ensure that it is a person-specific response across government departments, across institutions. But just one final question, and there are a few questions we didn't get to, and we will try and follow up in writing if we can. And thank you, there's a lot of discussion happening as well, but you know, what next? I think we've seen some positivity in the chat, but there's also a frustration there, I think, and that's come, you know, out in our consultations that, you know, is history going to repeat itself? You know, yet again, we have something that could be potentially transformative. We're on the brink, if not already in, an economic recession as a country. Tough decisions have to be made. Is the leadership there to drive this forward? How do we ensure, as a sector, you know, we're there to keep the leadership accountable, you know, to keep you accountable, Tom, and to keep your ministers accountable. But what next? You know, where do we go to next with this new policy? And, you know, guide us on what support you need from us as a sector to make this happen, because you've put a lot of work into it, and I think we all have the big final end goal there. So one final question for you both. Tom, do you maybe want to go first this time?
Yeah, well, as I say, the programme for government is quite clear. Certainly from the new government's perspective, mental health features as a very key priority. And as such, whether we liked it or not, the Department of Health would also then have that priority as well. But actually, what I've found from the beginning of this work was that this was a tick box exercise at the beginning. I think, Hugh, you'd agree that from the department's point of view, we kind of said, oh, I suppose we better revise it. But as the work went on, actually, you could see the implications of developing it. There was an energy that was built around it. And, you know, in some departments, it's very hard to get key stakeholders involved because they have their own policy agendas. But in fact, from the work that we've engaged in with education, justice, social welfare, there is indeed a very energetic, positive commitment to getting and working together. And actually throughout COVID, working with education and the Department of Children, we've worked on a great number of online interventions together, getting kids ready for leaving certificate results and things. So this collaborative way of working has already started. So I think from yourselves, you've been doing great in terms of getting all of your membership to write in about issues that are of concern. There are ministerial meetings happening, and they are saying, look, when does this start? I suppose the danger is trying to get the balance right, because if you start the implementation process now and pressure to do it quickly, it'll be set up and it'll be ad hoc, and it may not work as effectively as we'd like. The other side of that is you don't want it to be next year before it's set up, but the idea is, as I say, that we're thinking September for terms of reference drafted, and after that the membership should be fairly quickly developed. And as long as you keep putting the pedal on to say, well, when is the group formed, I think that's the key thing. But I know from a department and ministerial point of view, mental health is a priority, and I'm doubtful it will change. You know, it's a very important consideration.
Can Hugh here, my involvement in this on some level is finished now, because my role was around chairing the group, and I'm not involved in any professional way with implementation. But I go back to the point, the key piece for me is that implementing complex policy is a very complex piece of work, and it does require people with expertise in that whole implementation science. And I think if the group, if when the implementation group is set up, it needs to be supported by people, a team of people with that expertise, both at a central level and at a local level, to ensure that it's done properly. And if there's one message for me in terms of all the work we've put in, I think that's a critical, because all of us get involved in implementation with the best will in the world, and we put our heart and soul into it, but there's an actual science in doing it and doing it properly. And if that science is missing at the central piece and at local level, it just won't happen. If you look at some of the more successful changes that the HSE carried out in their own services, was when they brought in that kind of expertise from the Centre for Effective Services, that the support that they were able to give outside the people with busy roles was really, really important. And it would really be, for me, that's a key piece, that expertise, that science is included there.
Thank you both. Yeah, I think that is the science, you know, to move from policy to implementation. And we can also look at different countries. You know, one of the things that strikes me is sometimes, you know, the developed countries, we can also look at developing countries who manage quite well to go from policy to practice in areas such as, you know, HIV, among others. So, you know, there's huge opportunities there. But I think we could stay on discussing this all day, but I know people are eager to get to their kitchens, probably still, to get their lunches. And yeah, I just want to say, you know, thank you both. You know, it's been a very open, I think, discussion. Thank you for your insights. Thank you for your honest feedback. You know, it is going to be a partnership that will deliver on this. We're not always, you know, speaking to Tom in particular, probably not always going to agree on everything. But I think as long as we have the end goal in mind, you know, we'll keep battling and keep ensuring that, you know, the mental health services that people deserve are actually achieved in the course of this policy. So I think it's been a very fitting end to the first series of these coalition conversations. So Gurmila Moihagov, Vertigover Son of Anshanyu. So yeah, and thank you to everyone who has been participating both today and over the course of the 8 weeks. And I'm going to share, one of my colleagues will share a short survey. We're going to come back now. We don't know what the future holds, and when we're going to be back in our offices and away from our bedrooms, our kitchen tables and our home offices. But in September, we're going to come back and going to kick off with hopefully a half-a-day seminar looking at a particular topic, which we'll be in touch with and we'll be promoting in due course. But yeah, these conversations have been really engaging, and I think they're really going to continue and going to, you know, we need to challenge each other. We need to discuss with each other, and we need to create momentum and a movement in Ireland, because, you know, it's going to be hard to compete with a lot of interests that are out there in the weeks and months ahead. But I think we all believe we have something that can achieve change here if it's implemented correctly. So yeah, thank you all. And I'm going to end the webinar there, and I'll be speaking to you in September. So until then, enjoy the Irish summer, enjoy your staycation if you're having one, and we'll be speaking again shortly. Slán.
If you're on Slán, good.